So let's get started. So what about Registry and the current status? So let's start with a little cartoon. This is a problem. Um, this is a problem for registers as well, because if you amputate an above knee, then the registers don't pick that up, and your knee is still a success. So just be aware of that. If you can't measure it, you can't improve it. And I would urge everybody in the room to make sure that if they make some changes to their practice, that they measure the outcome for the patients. So conflicts of interest not relevant for the talk. Let's talk about registers. So first of all, register comes from the Latin word registrum, and that's things recorded. So register is a file of data related to population base, and that's the actual document. Registry is a system of ongoing registrations, and I know they're mixed up continuously. So whether you call the National Joint Registry and the Swedish Register, it doesn't really matter. So they just mean the same. So they go back to birth registers and death registers and disease registers, all started in the 16th and the 17th century. So what type of register do you have? You have causes of death, birth, delivery of healthcare, hospital discharges, population characteristics. You've got disease registers, you've got reimbursement registers, and you've got quality registers in Sweden. And Sweden is one of the starting countries about registers, and they've got more than 100 quality registers measuring anything from Parkinson's to diabetes to total hip replacement, total knee replacement, ACLs, spines, everything. So there is also a link with Codman. So Codman from the States started the registers in Harvard, and his idea was looking at the end result ID. So every hospital should follow every patient they treat long enough to determine whether or not the treatment has been successful. And if it isn't successful, why isn't it successful? In order to prevent similar failures in the future. So the Harris Joint Registry was one of the first registers that looked at their joint replacements together with the Mayo Clinic. And this has been recognized. The Kappa Delta Award from the American Academy was awarded to Henrik Malko and the groups around him. So Dan Berry from Mayo, Bill Harris from Massachusetts, Otto Robertson from Sweden, Johan from Sweden, David Llewellyn. So they all were awarded a lifetime award for their work on registers. So what is the aim? The aim of registers is analyzing healthcare institutions, their activities, stimulating continuous clinical improvement of care, research, post-market surveying, hypothesis generating for the RCTs that will be discussed with Mohit Bhandari. And nowadays we do register nested RCTs as well. So what you can see is what is the real world data instead of just an RCT where you just have a little bit of a limitation of some selected patients. So who's the registers for? Patients, surgeons, departments and hospitals, healthcare providers and groups, countries and government organizations, and the international community. But also we know that using registered data, you can improve healthcare's value. And I'm a little bit involved in value-based healthcare. And what I've seen is that using the registers in the Scandinavian countries, they were able to reduce the revision rate quite a bit. And if they would do the same thing in the States, or if they would have done the same thing in the States, they would have had 8% cost savings on the orthopedic budget. So you can adopt best clinical practices. We can talk about approaches in hip fracture surgery or using cement in hip fracture surgery, limitation of number of implants, and stepwise introduction of technology and implants. And going back to Henrik Malko. So value-based healthcare and registers, agreed outcome measurement sets. So we need to make sure that the prompts can talk to each other. Transparent and accurate recording. So what you measure is what you really need to measure. Reliable and timely communication, dissemination of outcomes, and I think we're getting better in this. The reports are getting earlier. The data is also getting better as well. And we really need to measure what is important for our patients. And if you measure all of this, what you can see is that nobody wants to be the last in the class. So we all want to be the best surgeons in the world, or if you look at it in a British way, getting it right the first time. So my involvement in the registers was my thesis, a couple of publications, and looking at the pathway of hip replacements. And then I've already mentioned this before on my presentation, I think on Friday, looking at stepwise introduction of new technology, the next level of dilemmas. So are we doing it right, introducing robots and new techniques and new technologies, or are we doing it wrong? Because we've failed the patients before by introducing metal on high scale and seeing that it wasn't really as good as it used to do. So Henrik, Henrik has really been involved in registers quite a bit, and he started with his thesis, which took him 10 years to write, but I think it's one of the most quoted theses in the world. And then he talked about innovation, And then the next critical role of orthopedic registers looking at register-nested RCTs. But no, we're in a technology meeting. So what do registers tell us about technology? I think long-term outcomes of technologies are still missing. And the NGR, there's absolutely no data as robotic is no part of the MDS. It's only this year, or the last set of MDS, minimal data sets, that we now have to fill in whether or not we use navigation or robotics. In the Australian register, there is some recordings of computer navigation, robotics, and patient-specific implants. And there are some publications. So there's two publications there. Use of computer navigation in total hip replacement is associated with a reduced rate of revision for dislocation. And if you use robots for unis, your outcomes are better. However, in this year's report, and I've highlighted in yellow, they say that the use of computer navigation and robotic assistance doesn't lead to improved outcomes, both in hips or in knees. But what are really saying? So this is from this year's report. You can see, so for unicompartmental, you can see that there is an increase in usage of technology assistance. But you can also see that on the bottom here, that is diverging. And the confidence intervals are not crossing over. Yeah, and the p-value is less than 0.05. So there is a difference if you use robotics or technology for your unis. So there is a difference. So what about total knee replacements? So on the left-hand slide, you can see what's happening with regards to the Australian surgeons, whether they use technology or not. So there is certainly an increase in use in technology. The robots are the green line, so they're increasing. But if you look at the outcome between computer navigated and non-technology, there's absolutely no difference. So you can see the p-values are higher than 0.05. The confidence intervals are overlapping. So we can't really say that robots, navigation makes a difference. And what about robots now? So blue line, no technology, green line, robotics. Despite the fact that the p-value is not statistically significant or doesn't show statistical significance, is that they're diverging and the confidence intervals are not overlapping. So at 5 years, there might well be a difference. But maybe it's a little bit too early and we don't know what's happening, whether this line is going to go crossing. And if it's crossing, then certainly they will be right. And the registers will say that maybe robotics is not really the way forward. So we talk about technologies. What about techniques? Well, I could go into detail, but we know that the registers sorted the problem out of metal on metal. It's also reiterating the fact that the use of cement in hip fracture surgery is the way forward. There's now more and more evidence from the Australian registry that patella use should be promoted, or replacing the patella in total knee replacement should be promoted. 6.6% of their revisions in Australia are for secondary replacing the patella, and there's an increase in no patella usage in Australia. Approach in total hip replacements, we had some nice lectures on direct anterior approach, direct lateral approach. There is a difference in approaches. However, the outcomes for patients, whether you use a DAA or a posterolateral, the PROMS data after 1 year is the same. New implants, we all know about new implants. The Australian Registry and now Kaiser Permanente have said that newer implants do not really improve the outcomes for patients. And head size, which has already been alluded to by Michael in the previous talk, we're talking, we know that the bigger the head size, the better. So in detail, arthroplasty for hip fracture surgery. So we know from registered data, cemented implants to be avoided, posterior approach completely to be avoided if you do a hemiarthroplasty, small heads to be avoided. And if you really decide to do total hip replacement in neurological challenged patients, you will have a problem. So what is uncertain as on the basis of registers the role of total hip replacements and the role of dual mobility components is still uncertain, although there is some evidence that it might be worthwhile considering. And that's where RCTs are coming in place, the RCT of Mohit Bhandari and the new RCT in Holland, as well in Sweden, where they will compare the use of dual mobility cup versus the traditional bearings. So what about the future of registers? So there needs to be national interest in the work and the function of registers, and it's always increasing. There's always room for improvement in the registers. The data quality is something that is sometimes the Achilles tendon of the register. So data quality must be very good. Buy-in from the professional organizations like in Britain, the Hip Society and the Knee Society. using the data to guide their surgeons. Register nested RCT is the future. International cooperation, looking at signals for failing implants if they haven't been used a lot in different countries. Just combining all the data in one register might help. There is a symbiosis between registers and value-based healthcare to make sure that the value of the healthcare that we provide keeps on being affordable. Use for evaluating technology and dashboards which give an immediately return to the surgeons to see how they're doing. So the past is the key to the future, and I think we talked about technology and techniques here, but don't forget the past. Make sure that we learn out of our mistakes and we just improve the care for the patients. So in conclusion, registers a robust wealth of data, providing additional information to support evidence-based practice, feedback and information for the four stakeholders: the patients, the surgeons and their professional bodies, the hospitals and the healthcare providers, and governmental organizations. You need to be aware of the limitations of registers, but I do believe there is some bright future for registers, and the role of technology should be evaluated within the registers as soon as possible. So next year in this meeting, we can just suggest what the evaluation of technology starts happening. Thank you.